Good afternoon, everyone, and welcome to the UNSW Disability Innovation Institute's webinar, A Forgotten Population, Australia's COVID Response for Disabled People, presented by Professor Helen Dickinson. I'm Jackie Leach-Scully, Professor of Bioethics and the Director of the UNSW Disability Innovation Institute. And I'd like to start with an acknowledgement of country. I'd like to acknowledge the Bedegal people of the Eora Nation, who are the traditional custodians of the unceded land on which the UNSW Kensington campus sits, and the Camaragal people, who are the traditional custodians of the land where I am now. I pay my respects to elders past and present, and I'd like to extend that acknowledgement to all Aboriginal and Torres Strait Island people here today. As we share our knowledge and practices across our communities, we also recognise the knowledge and experience embedded in the Aboriginal custodianship of country. If audience members have any questions during this event, or if anyone's having any difficulty and can't use the Q&A function, then please email us at diiu@unsw.edu.au, and that address is on the slide. Closed captions have also been enabled on otter.ai and via the Zoom automatic live transcription. And again, please contact us if you're unable to access them. We also have two Auslan interpreters from Sweeney Interpreters who will be on screen alongside the speaker throughout. The audience Q&A will be conducted via the Zoom Q&A function, and that's at the bottom of your screen if you're on a web browser or mobile device. So please post your questions here, and they will be passed on to the presenter during the Q&A session. Now, just a quick word about the Disability Innovation Institute. This is a World First initiative focusing on disability research, education, and knowledge exchange. Its team members take pride in undertaking work that is inclusive and crosses disciplinary boundaries. Our approach is to see disability not as a problem to be solved, but as an integral part of the human condition, to be encountered and engaged with rather than feared. And in this light, I'm delighted to welcome you to this, the fifth in a series of events called A Path Still Present, Disability Discrimination and Eugenics from the Nazi Third Reich to COVID-19. The aim of this series of seminars is not simply to consider these as historical events that are safely set back in history, but to consider them also whether this is in fact a path still present, that is, whether these ideas still influence attitudes towards people with disability today. And so it's my great pleasure to introduce to you our presenter. Helen Dickinson is Professor of Public Service Research in the Public Service Research Group at the School of Business at UNSW Canberra. Her expertise is in public services, particularly in relation to topics such as governance, policy implementation, and stewardship. Helen's published a jaw-dropping 19 books and over 100 peer-reviewed journal articles on these topics, and she can frequently be found in the mainstream media commenting on them. She's co-editor of the Journal of Health Organisation and Management. In 2015, she was made a Victorian Fellow of the Institute of Public Administration Australia, and in 2019, awarded a fellowship in the Academy of Social Sciences. And last year was named one of Apolitical's 100 most influential academics in government. She's also worked with a range of different levels of government, community organisations and private organisations in Australia, the UK, New Zealand and Europe. And so with that, I'll turn over to Helen for her presentation.
Thank you very much, Jackie, and thanks for inviting me to take part in today's event. I join you not from Canberra today, but from the unceded sovereign lands of the Wurundjeri people of the Kulin Nation, and would like to pay my respects to elders past and present. Many of the presentations in these series have started with a little bit of a health warning around the content of the presentation. And I think often that's due to the nature of the language or the concepts that have been used in them. This presentation doesn't draw from quite the same sort of historical context, but I do want to encourage us all to think about a bit of self-care as we go through. I hope I'm not going to give away any spoilers here, but the pandemic has generally been pretty terrible for many people with disability. At the start of the pandemic, people with disability were largely forgotten about. We did see some remembering and recognition around the time of vaccinations, where people with disability were prioritised for access to vaccinations, but a lack of implementation capacity failed to realise those intentions. And as you all know, the pandemic isn't over. Today, we find many of the public health restrictions have been relaxed, and yet we've got more cases than ever circulating. And I think a number of people with disability are facing an unending period of social isolation and having to take extreme caution out in public. So all of that's happening around this. So if it feels a bit too much at times, then do feel free to take a break. We'll record today's presentation, and I can also point you in the direction of a number of papers that myself and colleagues have written around these topics, if you prefer to read rather than to listen to some of these sorts of issues. So as you heard, I work at UNSW in Canberra, mostly in the fields of public administration and public policy. And what I'm going to talk today is about the idea that Australia's institutional arrangements around health and also broader services are lacking when it comes to ensuring that we can keep some clinically vulnerable populations safe in a pandemic context, and particularly thinking about people with disability. We've got a lack of a data infrastructure that can help us make informed decisions. And there's a lack of expertise around disability within a number of mainstream service areas. And I'd also argue that some of the policy reforms that we've seen over the last decade may have exacerbated this situation and made people with disability less safe. Some positives have come out of the pandemic in areas that people have been asking for a while, and I'll reflect on some of those. And, you know, the fact that change is possible, but we've still got some important gaps nearly 3 years into the pandemic. And arguably people with disability are even more of a forgotten population today than perhaps they were in early 2020. So I'm going to start by reflecting on why it is that we might expect that people with disability would fare badly in a pandemic context. So it's not uncommon for people to talk about people with disability as being a vulnerable population. It's not a language that I think is helpful, but I think for some people with disability, there are some clinical factors that may mean they're more at risk in a pandemic context. But there's also a range of structural inequities that create that risk. So these are socially constructed factors. They're not innately clinical in nature. And so in theory should be amenable to resolution or mitigation. I'm one of the leads on the Centre of Excellence in Disability and Health, and we do a lot of work around social determinants of health for people with disability. And if you want to have a look at our website, there's a bunch of different reports and resources that document some of these issues in a bit more detail. But in thinking specifically about the social determinants of health for people with disability, work by Julian Troller and colleagues at UNSW have consistently found a 27-year life expectancy gap for people with intellectual disability in Australia, 27 years. And that's largely due to deaths from avoidable causes. So if we think about health, not as a broader sense, but just in terms of health services, there are a number of ways that people with disability are discriminated against. The health workforce lacks capacity and expertise around disability. There's a lack of accessible forms of communication and information. Preventative health services are all often difficult to access, and so they have low levels of participation. And we see a lack of interaction between health and other organisations like education, social care, and across different levels of government. And some of these are outlined in the paper that's on the slide that appeared in Disability and Health that we wrote with some colleagues from Lancaster University, comparing COVID responses in Australia and England. And if we look outside of health, Australians with disability are more likely to be in lower socioeconomic groups, less likely to have completed school, less likely to be in work, and more likely to live in congregate settings such as group homes, and more likely to be socially isolated. So none of these factors are intrinsically linked to their impairments, but they're a result of structural determinants that make people more at risk in a pandemic context. So, for example, we see lower levels of employment for people with disability, not necessarily because they're incapable of doing particular jobs, but because workplaces are inaccessible, so is public transport, making getting to work difficult, and we see significant discrimination in hiring practices. And we see children and young people with disabilities expelled from school and education settings at higher rates than non-disabled children. And often it's due to a lack of inadequate supports and discriminatory attitudes. And all of these things kind of feed together in imposing a number of challenges when we start to think about health and healthy lives. People with disability might also be more at risk in a pandemic context if they require support with activities of daily living. So you've got people moving in and out of your home, so that can put you at a greater risk. And so many of these issues, I think, have some ability to be resolved if we kind of prioritize people with disability or think carefully about this in terms of policy. Now, it might feel like I'm overemphasizing this point a little bit, but I think it's really important in terms of how we think about pandemic responses. I think during or early on in the pandemic, at least, we saw a bit of a discourse emerge around the idea that we might expect vulnerable populations, such as people with disability, to be more likely to be sick or die in the pandemic. But I would argue that only some of that's about kind of clinical vulnerabilities, and some of the other stuff is tied into social structures, and so something that we should be able to address and do something about. So early in 2020, at the start of the pandemic, with Gemma Kerry and Anne Kavanagh, we wrote a piece outlining some of our concerns about the sorts of issues people with disability might face in a pandemic context. But we also argued that some of the trends we've seen towards personalisation, like those associated with the National Disability Insurance Scheme, might have the potential to exacerbate the risks that people with disability faced unless we saw some quick action taken. And so many of these issues stemmed from the marketisation of the NDIS and the associated casualisation of the care workforce. And so we argued that because of some of these changes, we no longer had a defined and identifiable care workforce. And that meant it would be really difficult to train frontline workers around things like infection control, to get supplies like PPE, protection equipment for workers out there, or to upscale the workforce if people became sick in large kind of quantities. We don't any longer know who the care workforce is or how to reach them. It's a bit more disaggregated than it once was. And in some ways of managing NDIS budgets, the employers are actually NDIS participants themselves if you're self-managing. And we felt that it wasn't fair that the responsibility for training, infection control and sourcing PPE should be carried out by those individuals in the context of a pandemic. And so we argued that the NDIA, or the Quality and Safeguards Commission, might instead have a role there, although we saw limited action with any great speed. And we were also concerned that there might be no guarantee that support workers might turn up for work, and if they didn't, what an alternative might be, given the things that have happened in terms of the care market. And given the widespread amount of casualisation, we were also worried that where people didn't have sick pay, they might be incentivised to turn up to work, even though they thought they might have some symptoms. So people in low-paid roles who don't have any alternative may choose to go to work even though they were sick. And it was a matter of literally months between us publishing this and most jurisdictions starting to agree to fund sick leave in care workers. And it was really great that it happened, but we were a little concerned that, you know, this hadn't been thought about a little bit sooner and put into place. So, you know, start by saying people with disability are more vulnerable in a pandemic context for a range of reasons, and that some of the Australian policy context might have also made people more unsafe. So did those predictions come true? And if we look internationally, we find that infection rates are higher in congregate settings, so in aged care facilities, disability group homes, and prisons, people where a number of people live in close proximity. We see quite high levels of infection, as you might expect. In other groups that face significant structural disadvantage, so if we look in the US at evidence around Indigenous Americans, we find that those individuals died at 3 times the rates of white Americans, and that people who are clinically vulnerable also died at 3 times the rate of the average population member. Actually, the evidence in the US shows that after age, intellectual disability is the second highest risk factor for death. So people with intellectual disability are much more likely to die from COVID-19, and that's borne out in the UK data as well. From data in the UK, we saw that people with intellectual disability were 8 times more likely than average to die. And of all deaths from COVID in the UK, about 60% of those were people with disability. So what do we know about Australia? I mean, the answer is we don't know. So we know what these figures are, we know what these tendencies are on an international scale, but we actually don't know what the figures are for the Australian context. So some of that's because Australia doesn't have a consistent disability identifier that's used in health data sets across all states and territories. So we don't know how many of Australia's 4.4 million people with disability have contracted COVID-19 or who may have died from this. And the nearest we have in terms of some ideas of levels is a significant underestimate. So the figures that are in the table on the slide are the figures for National Disability Insurance Scheme participants, although there's some significant caveats on how accurate this data is. So first of all, we know that, you know, there's 550,000 Australians who receive individualised funding from the NDIS, but that's only about 12% of people with disability in Australia. So these figures don't tell us anything about that other 88% of people with disability across the country. But these are also figures that have been reported by registered providers. So not all providers have to be registered with the Quality and Safeguards Commission, so that takes out a number of providers. And then these are also self-report figures as well. So providers are reporting these, which obviously is likely that it means that there's some significant underreporting. So these data suggest that we've had 91 NDIS participants have died from COVID-19. So it's smaller than something like 0.02% of participants, but it's a serious underestimate. And I think there's some work that's going on at the moment in different states and territories to try and pull together different data sets, so that we can get a more accurate sense of the scale of these sorts of figures. Not knowing what's happened here is really, really problematic. But we do have some research projects that have explored in real time what's happened in terms of Australia's response around COVID-19 for people with disability, and how that's impacted people's lives. So I'm going to talk through a few bits of those work and illustrate some of the issues before thinking about what kind of went well and what didn't go well in Australia's response, and what we might take from this. So in research that we did in 2020 with disability support workers in disability residential settings, given that congregate care settings were probably at higher risk than many others, we wanted to see what the response had been in those settings in terms of COVID-19. And what many people told us as we started out into this, as one disability support worker is quoted on the slide, I think disability has been an afterthought, and it means that we're not all in together. And many people talked about having been forgotten about, people with disability just not being thought about in the early stages of the pandemic. So we had a situation where we had clinically vulnerable populations identified as priority groups, and they were older people and Indigenous Australians, and specific plans were developed around those groups, and they were prioritised in terms of access to a number of services and supports. But at that stage, people with disability weren't identified. So not only did that mean that we didn't have plans for how to handle COVID, in this case in disability in residential services, and often they were told things like, well, just apply the aged care plans, which were often not very relevant to those settings. But in not being identified as a priority group, it also meant that disability services didn't have access to the national PPE stockpile. So we spoke to a number of providers who were having to work out how to procure masks and gowns and a range of other protections for their staff at a time when there was a worldwide shortage in PPE. There were some really, quite clever and innovative approaches taken to doing some of this, but it took an extraordinary amount of activity and effort to do some of that. And so with some colleagues at the Centre for Research Excellence in Disability and Health, we published a statement of concern talking about some of these issues in March 2020, and it was picked up and used by the Royal Commission, who pointed out that this was evidence that the government should have identified people with disability as a priority group, and that happened kind of shortly afterwards, as we'll talk about in a minute. But the point that was being made was that people with disability are experiencing significant challenges in accessing a range of services because of the types of inequities they face in day-to-day life, and they're not being addressed in policy as it stood. But 2 years after that initial statement back in March of this year, the Royal Commission was still making the point that people with disability were still struggling to access appropriate supports, and that this is in contravention to the United Nations Convention on the Rights of Persons with Disability, which Australia was an early signatory to, and states that people with disability have the fundamental right to health without discrimination on the basis of disability. We also did a couple of pieces of work around children and young people with disability and COVID-19. So I'm going to talk about two surveys. We partnered with CIDA on working with Sophie Yates and Catherine Smith as well. And in the first survey, what we wanted to explore was the impact of the pandemic on children and young people with disability and their families. So CIDA sent out a survey in March and April of 2020, And most of the responses were from parents, but they were talking about some experience some significant disruption to their lives. If you remember back to that point, there was panic buying. So there was a lot of certain types of foods, cleaning products, continence, medicines that weren't available because people had gone and bought them in bulk. If you could find them, they cost a lot more and were quite difficult to get hold of. And there were serious gaps in terms of the sorts of things that people needed to buy. Just over a third of people that we spoke to at that point had said that support services had cancelled, either the services had cancelled on families or families had cancelled services at a concern about bringing infection into homes. And about half of the people who responded to us said that either their mental health and well-being or that of their child had taken a hit over the last month or so. People told us there was general lack of information and things that they could get was not really in an accessible format. And there were some really contradictory messages at the time in the media. So people were being told that children weren't at risk from COVID-19, but people with comorbidities were. And so many parents were trying to work out whether or not their parents were at risk, whether or not their children were at risk or not, and we're finding it really difficult to get access to information or information that was easy to digest. And many families were juggling with this kind of sudden confinement to home when many of their supports and services hadn't caught up. And we concluded reporting on this survey by saying people across Australia have experienced work and home disruption, supply shortages and educational difficulties. However, all of these disruptions are exacerbated for the families of children and young people with disability. Reading responses, we gained an overall picture of a group constantly beset by difficult decisions and precariously balancing work, play, care, and education to provide the best possible lives for their children and young people. Many people can only manage these things when the world's operating as it normally does. However, this global pandemic, and especially when it was immediately preceded by bushfires, has thrown these precariously balanced routines off to such a degree that families are struggling to cope. Now, one of the areas that people talked about specifically was around education. And so CIDA wanted to do another survey that followed on from this, that explored educational experiences as we started to see the first couple of school closures by COVID. And I won't go into this in a lot of detail, but what was a bit depressing was that we found that many schools were consistently not implementing inclusive education, and that was before the pandemic started, and the pandemic had not really made things any easier. So often teachers were reported to, where they had students with additional needs in their classrooms. They were kind of sorting out the other kids in the class and then coming to work with students with disability last, or leaving that to parents to make the changes to curriculum and support children to do some of that activity. Real difference of opinion about whether NDIS funds could be used to support children in this context. Some people thought that, well, NDIS doesn't fund education, so we can't use any of those supports to engage children in school. Other people had a more liberal interpretation of some of that, were redirecting some of those resources in really innovative ways. But a general kind of sense that children with disability were being left behind, and that was both in kind of mainstream schools, but also in specialist schools as well. The final bit of research I'm just going to reflect on here comes out of something we didn't see a huge amount in Australia in the first kind of year probably of the pandemic, given that we didn't see the same sorts of outbreaks of COVID-19 as we saw in some other countries, and much of the public health response was managed via things like restrictions like extended lockdowns. So Australia didn't face some of the difficult decisions about access to healthcare resources, such as ICU beds or ventilators, that some other countries like England and the US and Italy did, although arguably that's been something we've seen more of recently. And in places like England, often what happened was clinical guidance was used to triage and ration access to critical care for people with COVID-19. And that was done using often a frailty index that was designed to predict outcomes for elderly patients. And the implication of that meant that when that was applied to people with disability, they would score more low on those indices, and so we're less likely to get access to clinical care, so things like respiratory support. In England, we saw a high-profile campaign and legal action that overturned some of those guidelines, but I think it's probably still safe to say that people who need assistance with daily living are less likely to get advanced respiratory support and more likely to die than other groups, as we've seen in the data. And we've also seen the widespread kind of blanket use of do not resuscitate notices to groups of people with disability, and without consultation with those individuals or those families. And so given that we've seen some of those attitudes play out in other settings, we wanted to understand whether Australians held similar perspectives around how we should use scarce resources. And we undertook a discrete choice experiment with about 1,050 Australians. So we asked people, if you've got if you've got a limited number of these resources, how would you make choice between who you would give these to? And we looked at different variables like age, whether the intervention would be effective, whether the person smoked, whether the person had children, whether they were a healthcare worker, and whether they had a physical or intellectual disability. I won't go through all the findings here, but I'm happy to share the paper with anybody who's interested in this. But one of the things that we found was that people largely were against giving ventilation to people with intellectual or physical disability. So we saw some clear community attitudes around discrimination play out in this context, and is why we argued that we can't just leave rationing decisions, priority setting decisions to clinicians and managers on the front line. We need some sort of explicit process behind this, because otherwise the attitude, the discrimination that people with disability find on a day-to-day basis, they'd also experience in this sort of context. It might mean that people would miss out on life-saving potential interventions. So we had probably about a year where we had not a lot of specific prioritization of people with disability and specific policies around this, but some of that changed when we got access to vaccinations. And so people with disability and disability support workers were actually prioritised for vaccination, along with older people and Indigenous Australians when the vaccination finally became available. But if you look at the data today, what we find is that the vaccination levels of people with disability have consistently lagged the general population, despite vaccinations being made available for priority groups about 3 months prior to the rollout for the general population. And again, data is difficult here because we don't know how many people with disability in the broad population are vaccinated. But we do have the data around NDIS participants. So if we think about the first 2 vaccinations, the vaccination level around the country sat at about 96% for 2 vaccinations, and the level for NDIS participants was around 90% for quite a while. In research we did with the disability workforce, we found really high levels of vaccine hesitancy, and some people left those care roles once vaccinations were mandated for those groups. And so, as we've talked about, there's a extreme casualisation in some of those workforces, and it seems that some of that has made some disability support workers very mistrustful of government, and so therefore rather hesitant when it came to COVID-19 vaccination. What was really interesting in our study is disability support workers weren't against vaccination in general, but there was something specific about COVID-19 vaccination that was a bit problematic. I think for people with disability, although they were prioritised in groups 1A and 1B, there was not a lot of attention paid to the implementation of those decisions. So we didn't see a lot of in-reach for vaccination to group homes or for people who couldn't leave their homes. So the expectation was that people would attend mass vaccination centres, which was okay for some people, but not all of them were either physically accessible. And particularly the larger centres could be really problematic for people who have sensory impairments. And there were very few options available around sedation for people who have severe needle phobias. In some research with CIDR, again, we found that when people went to GPs to ask for vaccination, as they were told to do, to go to those smaller settings if they couldn't access mass vaccination settings, GPs didn't know that they were a priority group and would turn them away. And so although we saw this prioritisation, it wasn't really put into place in an effective way. We saw some examples of good practice. So in Victoria, we saw the establishment of disability liaison officers whose role was to match up an appropriate vaccination experience with for people with disability, but it wasn't an initiative that was widespread, although it shows you can do some of that with dedicated resources. As I said, I'm not going to just talk about all bad news. Some good things did happen through COVID, as we just talked about. We saw the prioritisation of people with disability and disability support workers in the initial rollout of vaccinations. We've also seen the prioritisation of people with disability for antiviral treatments, although there's a lot of misunderstanding and a lack of kind of consistency in practice around who can get access to those treatments. We saw disability workers be mandated in terms of vaccination, although that's a position that might be being stepped away from more recently. And we did eventually see the introduction of paid pandemic leave for workers in some jurisdictions. Some congregate care settings did really interesting things in limiting movement of workers between group homes. So you know, often would have people who would visit up to 6 different group homes in a day. They were just being limited to 2 group home settings, and the staff were a lot more happy about that, and the residents were happier about that as well. And there's also limiting of movement between aged care and disability care, so people work across the 2 often. One of the really big, great things, and is something that people with disability have been arguing about for ages, is to be able to access telehealth through Medicare. Was completely not possible for a long time, and literally within the few weeks of the pandemic, it became possible. Now, there are challenges to that. You have to physically see somebody every 12 months in order to carry on using that service, but certainly that's been a change that's made a real big amount of difference for some people. I talked about disability liaison officers, and in some places their role is now expanding into being a person who will help more generally in terms of accessing health services. And we did see some specialist vaccination hubs pop up, so some sensory clinics and some in-reach a little bit after those prioritisation processes happened. But there's still a number of gaps in place. Obviously, we've had the lifting of most public health restrictions that mean that most public spaces are unsafe for people who have people with disability who may be clinically vulnerable. And despite the fact that we've had access to things like free rapid antigen tests, there have often been challenges for accessing those. And similarly, in terms of uncertainty about who's eligible for antiviral treatments. Although we did have a mask mandate at one point, there wasn't a lot of access to respirators, which are a lot more effective in these contexts, and also not fit. We weren't doing fit testing for staff members as well. So, and all of those are really simple things that can help, restrict the spread of COVID-19. Ventilation of indoor spaces, despite being a really important issue, has just not been talked about in many places, and we've not managed to move the NDIA very far on this as well. It seems to boil down to an issue of who's responsible. So in a number of these things, is it health who are responsible for it? If they are, is it federal health or state health, or is it the NDIA who are responsible for these sorts of issues? So we've seen a little lack of clarity over some of that. And we also saw that play out in COVID and influenza vaccinations, where people couldn't get both of them at the same time because the state government was responsible for one and the federal government was responsible for the other. So you couldn't have them as a joint experience. So what can we take from all of this? So I think it's going to be really difficult to develop effective future strategies without an appropriate data infrastructure. We don't know about what's happened to people with disability in the pandemic, or that how that continues to play out. I think the issue of intersectionality and of multiple and structural disadvantage, it poses real challenges to policy that likes to kind of put people into one box than others. So we were doing some work on communications with some government agencies at one point who wanted to do communications for Indigenous people. They wanted to do communications for people with disability. They wanted to do communications for older people, and whose minds were blown when they worked out that people might sit across those different boxes. So we need to think about how we can tailor for some of that and accommodate within policy. I think the pandemic's really shown a profound lack of disability expertise within states and government, state and territory departments of health. They've largely moved out of that space after the establishment of the NDIS, and so we haven't got people thinking about disability within those policies. And even when we do have people prioritize, we haven't got the implementation skills to be able to deliver those in an effective kind of way. I think one of the things that's hit me most consistently in all of our research is that people with disability aren't at all surprised about any of these issues, and are not surprised that they've been forgotten about in the pandemic. People say, well, this is an illustration of the inequities and the discrimination that we face in everyday life. And in some senses, we've had the pandemic shine a bit of a light on and illuminate some of these issues that we face all of the time. So as researchers within the work that we do in the CRE and beyond, the challenge for us is to build on some of this and build on the positives that have happened, and some of the research that's provided insights, and think about how we might advocate for change. I'll stop there. Usually, if you know me, when you see a presentation by me, there's usually some form of animal behind me somewhere. There hasn't been one today, so I'll finish there with a wee picture of one. But thanks for listening.
Thanks very much, Helen, and thank you for that final slide as well. I'm kind of disappointed not to have seen any of your animals in the background, but maybe they'll take the hint and come along in the next few minutes. That was wonderful. Thank you. It was a really helpful and in-depth look at what's been happening with people with disability over the last couple of years in terms of COVID. I should say something that I forgot to say at the beginning of the webinar, which was that some of you will have been expecting to see Professor Anne Kavanagh, who was initially online to do this webinar, but due to unforeseen circumstances, she had been unable to do it. And so Helen, who many of you will know works very closely with Anne as well, has been able to step into the breach. So we're really, really grateful for that. I've got a couple of questions here, and I'm going to start with one from Julie, who says, do you think there may be some level of discrimination present in government services?
Well, undoubtedly, yes. I think when we look at, we saw it recently in the Royal Commission inquiry into kind of people who take kind of public transport and doing various things in their life, that people experience large amounts of discrimination. We've found it in a health context, and so undoubtedly there is some of that in there, and community attitudes plays a role in that. That's not something you can deal with overnight. So that's why I think we need to make people think about some of this stuff in more explicit ways, and have some ways of writing policies so that people think about some of those issues. I think one of the challenges is, I don't know if sometimes people aren't even being explicitly discriminatory. They just don't know people with disabilities. They've never thought about what it is to live a life as a person with a disability and what that might look like. And so we end up making lots of assumptions around things, and to some degree disability is not unusual. We see that play out in different ways in other sorts of spaces as well. So people just make a bunch of assumptions about people's lives and how things will be, rather than necessarily always being actively discriminatory.
Thank you. The second question here from Blair, and please do keep the questions coming in the Q&A. The question from Blair is, thanks for your talk. The pandemic has shown not only how disabled people have been overlooked and forgotten, but how many other people do not care about our lives, don't care about disabled lives. Do you think eugenics has played a role in how disabled people are seen? And second easy question is, and where can we go from here?
Oh, very easy. Look, I am not an ethicist. I am not a historian, and I don't know enough about concepts of eugenics to have thought through whether I think this is an example of eugenics. As a public administration, kind of public policy person, I look at this and say, to some degree, is it any surprise that we got to this stage where people with disability were forgotten? Well, not really, because there's not many people with disability who are involved in making these decisions. There's not a huge amount of co-production. There's not a lot of expertise about what it is to live your life as a person with disability. And so therefore we're developing policies in these sorts of ways. So I think we've got some real, and we've got very little evidence, very little data around some of this stuff as well. So I think there's real institutional shortcomings in how we've developed that response, and optimistic that some of the things like the National Disability Data Asset and other things may help take us further down that route. So that's an initiative that's trying to bring together a bunch of different administrative data sets so that we get a better idea of some of the kinds of issues that people with disability face with their life and how they cross across different types of service contexts. So Jackie may have a view on this and is more professionally situated to think about whether this is an example of eugenics, but I see it probably in a slightly different way.
Yeah, I won't say very much. Say that I'm actually going to be addressing whether prenatal selective technologies, for example, are eugenic or not in the next talk in this series. And in some ways, that stands for many of the kinds of things that Helen has been talking about as well. Just how do we separate actual eugenic thinking from what you might call straightforward discriminatory thinking, and how do we do that? Is it necessary to do that? I think it is, and so on. In view of that, and I think there's a really interesting question there about that lack of data. I mean, there's always a bit of a tension in sort of looking at that kind of thing and thinking, how much of this is almost par for the course for maybe an overstretched service or a marginalized communities, access to services and so on, and how much is there something which is distinctive perhaps about people with disability or the disability community in the way that they slip so easily out of sight. That was one of the first things that you said about the way people became invisible. Do you want to comment on that at all?
Yeah, and I think it's probably worse now than it is at any point during the pandemic, because I think many of us have kind of, you know, it's been a big trauma for everybody. Everybody's gone through difficult sorts of times, and everybody wants to believe that we can get back to some level of normality. And, you know, it's interesting seeing in social media interactions the number of people with disability attempting to remind people that not everybody can go back to, you know, normal day-to-day activities. Some people have not been very far out of their house in the last, you know, nearly 3 years because of concerns around infections. And so I think, you know, it's ironic that I don't know if irony is the right word, but it's probably disappointing that we've gone through this trajectory of kind of policy identifying people with disability as a priority group, trying to do some stuff and then just forgetting, and then just, you know, going back to normal and not doing any of that sort of stuff. And so I think it's probably the most dangerous time in the pandemic is at the moment, which is when everybody's decided that it's over.
No. Yeah, almost like they're deciding it's kind of too hard. You know, they showed willing, but really it turned out to be too hard in the end. I wondered, also, there's a question here too about whether you think that what's happened, those experiences over the last couple of years with COVID in Australia and even elsewhere, have politicized the disability community in any way? Have they been able to sort of draw together to push back against some of that, or has it just all been so, you know, doubly overwhelming that sheer survival is the priority?
Jackie, you've done research in the disability sector long enough to know that it's possibly the most political sector you could do work around, and most of the people with disability who I know are incredibly kind of politically engaged, and you know, across a number of different agendas, not just around disability. I think it's been a really difficult time in the disability community, in the sense that, yes, there's all of the COVID stuff that's been happening, but also we've had alongside that, we've had the Royal Commission, we've had a number of different proposed reforms around the NDIS that were very that people were, you know, strongly disagreed with. And so I think it's felt that there's been so many different campaigns that have been on at the same time. You know, there's been a number of different hearings around kind of the refreshing of the National Disability Strategy, things that we're involved in around the National Disability Research Partnership, the National Disability Data Asset. I think there has been so much going on, and that people, you know, went at such a pace in the early stages of the pandemic, when for a lot of people it seemed like it would be time limited. I think everybody's really exhausted, and that's something that you know, and I think that also leads to some of the frustration that we're seeing at the moment, when, you know, your previous question about people feeling that they're not being seen and not heard at the moment. I think people are feeling real frustration, having worked really hard and been really engaged for the last couple of years to come across these sorts of issues.
Now, one thing I remember from the early days of the pandemic was as everybody became restricted in what they could do, it was, you know, shut indoors, they were in fear of health issues and so on. They were unable to see their friends or go to work. And there was some commentary by many people with disability about how perhaps this would enable some non-disabled people to understand what everyday life was like and had always been for people with disability. Do you think that's worked?
Yeah, I don't know about I think it may have done, and some people may have seen it for a bit, but then I think everybody feels they've been through such a mass trauma, and everybody's you know, whether that's being ill themselves or lost, you know, had family members be very ill, or lost people that they know, people have, you know, everybody who's been at home with kids of whatever ages know that it hasn't been an easy sort of process. So I don't know that people have managed to kind of reflect fully on some of that sort of stuff. I think if people had, we might have been now seeing more of some of the accommodations that had been made would be sticking around. So it's been really sad for me to see you know, whether that's organizations, companies, public services, to call people back to the office when, you know, working from home was a really great accommodation that could allow for many people to engage. You know, we saw many events being undertaken in kind of a hybrid form as well, so that people could engage in that. And we've seen a dropping away of that as well. So I think I'm less positive about that mass learning experience than I might have been at one point. But hopefully it's stuck with some people.
That's a final comment here I can see from Blair, who's picking up on that and saying that letting rip has sort of clawed those positive changes back. Do you think we'll see a return of any of those accommodations in the future, or do you think that trajectory back to trying to be normal is going to continue?
No, I would think, you know, I mean, we're all meeting here like this today, and certainly, you know, I've you know, I've rethought where I work has rethought significantly about some of this. So I think we've seen some pockets of that, and interestingly, in quite different research away from this research that we've done around different public service workforces, certainly we find high levels of productivity and people feeling, you know, not just people with disability, people, you know, most people finding those kind of hybrids being a really positive thing. I think, you know, there's always a bit of a snap thing of wanting to go back to the way things were before to make things feel normal. But hopefully now we've had some of the experiences of doing some of that, we will have some more thought given to some of these sorts of things. And as I said before, I mean, one of the really lovely things about the last few years is I've managed to work with a lot of children and young people, a lot more than I have done before. And they have always blown me away in terms of how they think about being really inclusive and you know, how they think about mixing things up in different sorts of ways. So I'm hopeful that that we'll see some of that some more of that in the future. Okay.
Thanks a lot, Helen, and particularly for ending on that optimistic note. I think that brings us pretty much to the end of our time. No animals, but never mind. Thank you, everybody, for being with us as usual. There will be a recording of this available on our website together with the transcript in due course as soon as we can do so. And remember that the next and final event in this series of Past Still Present is in 1 week's time on the 30th of November at the same time when I will be talking about prenatal selective technologies and the question mark of whether that can be considered eugenics. So thank you very much for being with us today, and goodbye for now.